Gracefully Graying. I am your host, Attorney Henry Gorin Bryan. Today on Gracefully Graying, I am pleased to welcome as my guest Dr. Brian Gietzen, who is a specialist in one of the most important areas of medicine, and that's helping those of us who are reaching the last phases of life, for lack of a better word. So I'd like to welcome you to Gracefully Graying. And first of all, Dr. Gietzen, if I can call you Brian, I will. We're very informal.
Either is fine.
Why don't you tell us a little bit about your training and background?
Yeah. So my training here is here locally. I did my medical school training at Wayne State University in the late 90s, and then did my residency in internal medicine at Beaumont Hospital. So all here in Southeast Michigan. Have been in practice since 2000, and over the last 15 years we have focused predominantly on trying to provide care for our elderly population.
So you're dealing with really gerontology, for lack of a better word.
Yes.
And what made you decide to focus on that area of practice?
You know, we found, so I found the greatest enjoyment for a couple simple reasons. They were the relationships that became the most involved, and it was often the population that we were able to provide the greatest benefit for. So for both of those reasons, particularly, that was what drove my interest and ongoing focus on that area of the population. So,
now, do you have an office, or is most of your practice traveling directly to the patients, I guess?
Yeah, so we do have an office. I always tell our patients it's more of a suggestion than it is reality. So it does actually exist. We do see patients in our office, but I would say by far and away the majority of our care is provided right at an individual's residence. So we go to approximately 60 communities in Southeast Michigan between Oakland and Macomb counties, where we provide direct on-site care to the patients that we see.
Now, is most of your care at assisted living facilities, or do you go to homes? Tell us a little bit more about how it works.
Yeah, so it's a mix. We do some work in the hospitals. We're on staff in 3 of the local hospitals.
What hospitals are you on staff at?
So we round specifically within the Beaumont system and Extension, and then use coverage, but are also on staff in Henry Ford. We also do some rounds within some of the local rehabs, but by far where we do most of our work is in what are called independent living, assisted living communities, senior group homes, and then we do a smaller amount in private home residence as well. So all those settings.
And I know that's a huge growth area. There are more and more independent living and assisted living facilities opening up throughout this area all the time. Brian, what is polypharmacy?
Yeah, so polypharmacy is really, first of all, it is probably the most common talk I give, and I'm giving this to an elderly population. Most of the time when we start the discussion, individuals have no idea what this is, and in a sense, this is a really simple concept, and it's simply what it means is an individual that's taking more than one medication. So anyone who's on 2 or more prescription medicines is by nature dealing with polypharmacy.
I'm curious. First of all, what are the demographics, the ages of most of the patients that you see?
So for the population we manage, most are in their mid to upper 80s. I would say in this, what we call geriatric setting, the youngest we will start providing care is probably early 70s, but most are going to be between probably 75 and 90 in age. So.
And how many of the meds are typical?
Well, you get the gamut, but I would say more times than not, a given individual is on anywhere from 5 to 15 different prescription agents. So,
wow.
So well above two. So,
what are some of your concerns about polypharmacy?
So, one thing that we have clearly shown in medicine is that the possibility of having an adverse reaction to medication goes up the more medicines we are on. What we've also shown with clarity is the older any of us get, the more sensitive we are to the side effects of medications. So simply what we see in that population I was just describing is a really high rate of adverse reactions to these medications.
Do drug companies, are they cognizant? I mean,
Yeah.
we're inundated. You watch any TV show and it seems like the bulk of the commercials, they're either insurance, cars, or drug companies.
Yeah, well, I mean, you watch the drug commercials, and obviously they go through their full
Right.
list. You
But
pull
do
out.
people pay attention to that?
You know, everybody's a little unique because it gets a little overwhelming. You pull out that little package insert
Right.
for anyone's on medicines,
Right.
and the first thing they see is a list of maybe 100 or 200 possible side effects. So what happens is that becomes hard to develop context. The information that's provided, I often find, is of some limited utility because it doesn't tell an individual what are the side effects I should be worried about, which ones are potentially more dangerous. It just kind of gives you this long list. It could also, for clinicians, so physicians, become somewhat overwhelming to attend to the side effects because they're not always singular. What I mean by that is, so I'll say for our population, the biggest side effect we see from polypharmacy is traumatic falls.
And that's serious because often someone's doing well and they have a fall, broken hip or something, and then they start spinning into a serious and often a fatal situation.
It's these traumatic falls are often life-changing, and part of the problem is falls are going to occur with or without medicine, so it oftentimes is a unrecognized phenomenon. So, because I'll talk to patients and I'll ask them, well, how do you know if your fall was from medicines, right? How do you know? You don't know. For any one individual, the falls, the stories they relate are exactly the same, but what we have seen is by trying to be judicious with the amount of medicines that we provide, the rates of traumatic falls really do drop dramatically.
So how do you monitor this?
The number of medicines that an individual is on, or fall rates, or all of the above. Well, the fall rates, so in the communities we work, we'll often ask that they help track for us how often our patients are being sent to the hospital. And then we'll often use their historical data, and we just see the rates of hospitalizations drop dramatically as we drop their medications. When we do this, we have to be mindful because obviously there's reasons why people go on medications to begin with. So we ask a fairly simple question, which is, do the benefit of this medicine that you're receiving, does it outweigh the risk?
And how do patients know? I mean, let's face it, most patients, we trust our physician.
Yeah.
We look up to you. If you're saying go on this medication or that medication, I mean, some people question it, but by and large, most people will say, okay, that's what the doctor ordered.
Yeah. So, the question is how do individuals end up on all these medications to begin with? So, I would say by nature, most people come to us on these medicines. So I am not necessarily there right at the time of decision making, but I would presume the general approach that leads to the medications is what we call treatment off of indication. So let's say you go into the hospital and they're worried you have a heart attack. There might be 3, 4, or 5 medications that are indicated for that problem, so you'll end up on those medicines. That question that doesn't get asked, though, is the benefit of these medicines worth the risk? And that balance changes, as we age. So,
well, what you said earlier, as we age, we're more susceptible, we're more vulnerable. So if anything, some of the contraindications are, I guess, more salient.
If I have a 50-year-old that we're treating, it's very rare that I have serious concerns about medication side effects. But our 75s, our 80s, our 85-year-olds again, with the biggest complication being traumatic falls, it becomes a tremendous concern. And because, again, this is a population that can fall even off of medicines, it's often unrecognized by the healthcare industry that these two items are connected. So from my estimation, it is a epidemic.
So how do you deal with this? I mean,
Yeah.
it's an epidemic. I mean, the drug companies are under fire. You've got so much over medication. You've got all the issues of the drugs that are, for pain meds and the overuse of that. But how do you deal with it? I mean, you spend time with each patient. I mean,
Right.
is it part of the workup? What are you looking for?
Yeah, so obviously each medication is going to have a slightly different assessment.
Right.
But within our group, we are always, whenever we sit down together as a group, we always will look at medications, and we will ask as a group, how are we going to define how beneficial a medication is and how potentially risky is the medicine. So we develop out what I would call protocols, ways to ask that question for each of the variety of medications that we would be responsible for.
Give us an example of a protocol.
Yeah. So one common class of medicines that can certainly generate falls is blood pressure medicines. And what can happen, and this again we don't see typically in younger individuals, but we do see in those who are aging, is as they go to stand up, their blood pressure will drop. The majority of people who we establish care on have never had their blood pressure checked lying, sitting, and standing. So that's one of the very first things we do. And if we see substantial drops in that blood pressure, we'll start asking the question of whether or not we should start cutting back, discontinuing, and we'll make that assessment by also looking at how steady are they. If they already have other reasons that they're unsteady, we're more likely to tolerate a drop in blood pressure. So,
Brian, does the blood pressure go up as we age, or?
well, the blood pressure goes up as we age, but the tendency for it to drop when you get up also goes up as we age. So that very quickly becomes more dangerous for someone who's unsteady than a high blood pressure in and of itself.
So what do you tell someone to kind of think it through and kind of ease yourself up, or what?
If we are seeing large drops, the very first thing we're going to do is start cutting back on those medicines. Yeah.
Brian, what about the issue of too many cooks in the kitchen?
So I'll speak to how our practice handles. Yeah, that
Yes.
can be an issue. If you have 2 or 3 doctors who are all managing the same medicines and it's just whoever the individual saw last, you very quickly can create confusion. So one of the things we have developed internally is we are very mindful of who is prescribing what medicine. So as primary care, there are times where we do need the assistance of specialists, but we then make sure we are very mindful of what medicines and problems they are managing, what medicines and problems we're managing. And what we will do is, even when it's a medication that the specialist is managing, we're still setting up assessments to see if there is concerning side effects. If we see them, then typically what we're doing is contacting that physician and making them aware of our concerns and asking them to then make a decision.
Now, Brian, you're
Yeah.
part of a group. How large is the group?
So our group has a total of 5 clinicians, so 2 physicians, and then we have 3 what are called mid-level providers. So we have 2 physician assistants, and then a nurse practitioner.
So you'll be seeing the same patient again and again and again. It's not as if a patient will go through many hands. Is that
Right.
correct?
We have, for each community we go to, we have 1 physician and 1 mid-level assigned.
So
yes.
that way you're really able to focus and regulate things.
Right.
What are some of the dangers of taking away or weaning someone off of medications?
Yeah. So, there's there was always a reason the medication was started.
Right.
So, when you've had a heart attack, we'll use that again as an example. One of the primary reasons these various medications are started is to try to prevent a second heart attack. So when you go on blood pressure medicines, when you go on a cholesterol medication, that's really the reason for those medicines to be given. So by nature, there is, if we were to discontinue those medicines, the possibility that risk will increase. The question becomes by how much? And oftentimes that increases by not nearly as much as one might think. So, but if you don't ask that question, we find, even for clinicians, there's a tendency to overestimate how beneficial a given medicine may be. So,
well, is it better to be on as few medications as possible if you're able to?
So I'll always go back to, you want to make sure if you're on medicines, the benefit you're getting from them is greater than the risk. And as long as that balance is to your positive, then whatever that mix is probably going to make sense. But as soon as that starts going upside down, yeah, by nature, that's how our group would define you're on too many medications. You're actually being exposed to more possible harm than benefit.
Brian, what are some of the most overly prescribed medications for seniors?
Yeah, so particularly if we have a conversation about the side effects, again, that we worry most about, the number one being traumatic falls. The class of medicines that has the highest rate of causing injury is one that in a younger population is pretty well tolerated, and that is our antidepressants. And it is a tricky problem. There is no doubt as we all age, the rates of depression do increase. But what these medicines do is they create a degree of what I call clumsiness. So if you're already a little unsteady and now we make you clumsy, it becomes a really bad combination. So, so we see a relatively high rate of use of these medications. So it concerns us because of that connection. What we also see is oftentimes prescription of these medicines on a symptom-based level. So, what do I mean by that?
Yes.
Having a depressed mood is actually not the same as clinical depression.
But do people recognize that?
So we will often see that question hasn't been asked. So I'll give an example. Let's say you've just lost your spouse.
You're going to be depressed.
You're going to be depressed.
Normal.
And that is normal. And also the antidepressants don't help that individual. But we will see a high tendency of prescribing in those kinds of settings. So we see a very high rate of use of antidepressants. We are oftentimes concerned that the person had a depressed mood, but not clinical depression, and then we're really worried about the possibility that these medications will generate a traumatic fall. So those often are the ones that, when we're going through a new patient and looking at their med list, those are the ones that kind of stand out to us.
Tell us about some of the worst cases of polypharmacy that you've seen in your career.
Yeah. Well, it may depend on what perspective you use, but this is what I will see is, so again, biggest complication is someone falling and hurting themselves.
Okay.
We'll see those individuals go into hospitals where we're not on staff. Then they will come out on 3, 4, 5, or 6 new medicines. And so for us, that is always of great concern, and it's always interesting how that plays out. So what we will see is, again, if you are 75, 80, 85, when you are in pain, the tendency for your blood pressure to go up is much higher. Our blood vessels just kind of stiffen like everything else.
Sure.
And so with stiff arteries, pain or distress, they can't expand, so what happens is your blood pressure will elevate. There's actually no specific risk to that phenomenon, but we will find it very quickly will lead to sometimes multiple additional blood pressure medicines. Again, with the understanding that these are the medicines that can cause falls. So we'll see individuals go in with a traumatic fall and then come out on a higher risk regimen after that hospitalization.
Well, is the problem that hospitals are too quick to medicate?
Yeah. Well, so I say one thing to be aware of is when you're in the hospital, people have their eyes on you constantly.
Right.
And so we'll see a couple things. So we'll see a short-term elevated blood pressure. That can be very hard to ignore. We can all of a sudden see monitoring of conditions that were actually chronic in nature. The patient was tolerating it just fine, but now because people are seeing it, they want to do something. So we'll often see people who chronically have, let's say, a little bit of retention when they want to go to the bathroom and urinate. All of a sudden, you have a nurse come in scanning the bladder. They see these numbers. It worries them, and so all of a sudden you'll see medicines or catheters. So there's a variety of factors that lend to these medication regimens actually escalating at a time where it was potentially a complication of medicines that brought the individual in the first place. But what we also see, unfortunately, is a real high tendency of not recognizing in our elderly population how dangerous medicines are. That's almost across the board. So there's not, the question oftentimes isn't asked.
Brian, what should you do if you're a child or other family member and a loved one isn't doing well and you're concerned that there may be over-medication or you don't even recognize it?
Yeah.
What advice would you give to someone in that situation?
Yeah, I always, so if you have a family member who is falling or who is almost falling, that's if the chair wasn't there, as they reached out, the first thing I would be doing is getting out to your doctors and asking them, can you look at this list and see, are there any medicines that might be increasing my mother or father's or family members' fall rates? I think it's always a fair question outside of that to try to have a conversation also with your physician. How much benefit is this medication providing me? That's always a good starting point. Do you see any potential risk or harm in being on this medication? So hopefully you start kind of cueing that as a thought process.
But how do you get someone engaged in that? Because I think a lot of people, again, we go back to the fact that we trust our doctors, and a lot of people don't know what to ask.
Yeah.
So how do you get them to engage? I mean, what would be your role in that situation?
Yeah, I think so as the patient or the family member, you want to try and just express that you have these concerns. You want to encourage that conversation with the physician because oftentimes it may not happen from their perspective. So what in my experience outside of our group where we're already mindful works best is general questions about, are there any side effects that I should be worried about, as opposed to a specific conversation about a specific medicine. But the flip side is if you've read that side effect profile, you're having those symptoms, I certainly would encourage individuals to bring that up.
Brian, what do you find most rewarding about this area of medicine? And you're dealing with people really basically at end of life, often in crisis, so it's a tough area.
Yeah. So I'll go back to one of our earliest comments. So the ability to really make a difference for this group, really in my perspective, is much greater than any other population. So I'll make note that when we ask an individual, would you like us to see if we could get rid of some of your medications? 99% of the time the answer is yes. When you add to that all of a sudden they start feeling better, they are able to do more, the appreciation that comes from putting people through that process is great. So to us, the fact that we can make people healthier by doing less and the appreciation that generally then follows, like I said, I haven't found anywhere else in internal medicine that generates that same kind of reward. So
that's beautiful. What about frustrations? Because you're seeing death, you're seeing dying, so what are some frustrations about this area of medicine?
Yeah, well, so it is a complex population that we deal with, both medically, socially. You might have 5, 6, 10 individuals who are all interested and connected to a patient's care, trying to be effective and efficient in communicating can be a bit of a struggle. It's interesting, as far as death and dying, the majority of individuals that we're caring for, they're at a point where that is actually a desired outcome. So to be able to help people move through that is actually probably more rewarding than it is anything else.
So a lot of what you're doing is really comforting people through what could be the last stages of their lives, or perhaps helping someone through a crisis where the idea that the meds can help and there can be a reward where someone gets better.
Yeah.
Brian, what are some final thoughts you would like to share with our viewers before we sign off?
I always encourage for anybody who feels a little bit unsteady, so this can be 30 or 40 years old as well,
Sure.
who are on multiple medications, to take the time to have a conversation with their physicians. Be comfortable that they are appreciating both sides of not only what that medicine can do, but what it can potentially cause. And don't hesitate to bring those concerns up. I often find by simply making the physicians aware that this is something you want to talk about, it will open up a conversation that often can lead to a few less medications. So.
I mean, a takeaway really is that it seems like with regard to medications, yes, often they're important, but in many situations, less is more.
You know, so I'll give this as a brief perspective when we go to an assisted living community. So this is a population that is a little bit more fragile, and we use these techniques of trying to limit medications. Our experience is the rate that these individuals go to the hospital decreases somewhere between 80 to 90%. To me, that speaks to the potential harm of these medications. So
Right.
This is not a trivial problem. It may be for our elderly population the greatest risk that they're exposed to. So for us, being able to see those kind of outcomes creates a passion, and certainly our goal is to continue to try and push that message forward.
Dr. Brian Geetson, we're running out of time. First of all, I greatly admire what you're doing. I think you're serving such an important segment of our population. I want to thank you so much for being my guest on Gracefully Graying. And I want to thank you for watching Gracefully Graying. This is such an important area that we're covering. Thank you.